wanted to share with you one of the things that I think is pivotal. You've already been making jokes about being phaco-handicapped and and so on. And there's an important point in all that, not just a funny point. And that is that I think things really are taking a bit of a turn in our world. You all are, I think almost all of you are old enough to remember, the practice-changing moments in ophthalmology when someone says you can use a laser to resculpt the shape of the cornea. And so, PRK came on the scene, and it was, oh my gosh, we've got a whole new opportunity facing us, a tool that we can use to really do some extraordinary things to address the needs of our patients, change the face of ophthalmology forever. In a way, and I won't say it's on that same scale, but in a way, I think there's been a movement, an underlying thing that's been developing for some years now. It didn't just suddenly drop on the scene like PRK did, like laser did, but it's been slowly kind of taking shape and taking a form. And I think we're at a point now, and this meeting is one evidence of that, I would say, that manual small incision gives us a very unique opportunity now to address things in a way that we really couldn't have done so in the past. So I wanted to talk with you this morning just to kick off this meeting. That really is the focal point of this. It really is. That's what you're here for, to be a part of that, to be a part of this change, to not be just not be narrowed in on phaco only. I'm not saying that's bad, of course. We're not talking about let's get rid of phaco. We're talking about, do we have a tool that we can add to our toolkit that can help us address some of the global needs and do so really, not just talk about it, not just make plans, not just think strategies, but actually to go out to the front lines and get it done. So I hope that's what you're here for, to be some of those who will want to and be able to be part of just let's get it done. So if we can get great, next. So I just wanted to give you some idea. And, we've all been faced with the realities of blindness with the aging population and so on. This was a study that was commissioned for the RAND Corporation to do. And basically it shows the reality. And next. Click forward. This is where we live. We live in the place where most of that need is met. But I want to point out that what you're going to see today is the fact that not all of that need is met even here. You're going to see patients that are from Dallas, that are blind, that are having M6 done. That's what you're going to see this afternoon. And there's quite a few of them that have already had M6 here. And I think in some other places around the country also. It's a viable alternative when you're faced with advanced pathology. And advanced pathology almost always, not always, but almost always goes along with limited access. And sure enough, even though despite some of the efforts we've all made, I know you have in your practices, okay, I know they don't have insurance, but okay, let's give them an appointment. Let's see them. I know you've all done that, but you can never get that to scale. That just won't happen. You know why? Because you are adding more. You're eating through your revenue as soon as you start doing that. And if you try to scale that up, how are we going to do that? We can't do that. So anyway, this presents an opportunity perhaps to do that. And I want you to look at the model we're looking at today here at Cornerstone, and think about your own situations and how. The next slide, how do we address that part of the circle? Those, of course, represent other places, Africa, India, China. So you can see we've got, a significant issue to face. If you look at just the percentage of cataract surgery that's being done, that is increasing. There is increased capacity in the world. So it's a little confusing when you read the literature because it sounds like, well, we're winning. We're getting there. We're making progress. Well, yes, we're making progress, but I would say we're not winning. We are not nearly to the point of really addressing the problem. And that's going to take some new thinking, some new ways of looking at how we address this. And we're going to have to put our heads together to do that, to come up with the solutions to make that happen. Next. So this is, it's not just about the number of surgeons either. So when you think about solution, next, it's about the productivity of surgeons. So if you took just the surgeons who are out there today and say, I want you all to do 2,000 cases a year, or something like that. If you look at surgeons who are working in developing countries, very often the case is maybe 200 a year, maybe 300. That's really a productive surgeon. So if you took all those surgeons and let's all do 2,000 a year, how far would we come towards meeting the goal? Anybody know? It'd be about halfway if you took the surgeons we currently have and turned up the switch and said, okay, woohoo, and they all went, yay, they all, suddenly started being very productive. They had all the supplies they need, they had all the time they needed, they had all the motivation they needed to get it to start being very productive. We'd meet about half the need. Next. The quality is another big issue. One of the reasons the outcome or the productivity is low, the quality in the RAB studies, I'll show you in just a minute, productivity outcomes are a real problem. And what happens when you have bad outcomes? Well, surgeons unhappy, patients unhappy, cost is higher because what happens? It takes a lot longer to take care of those people afterwards. You spend most of your time taking care of the problems, not curing the problem. Next. Access, of course, is a part of this issue too. You can't just produce high-quality surgeons and not have patients. This is about giving patients access to that service. So the cost of the provision, we've got to find ways to deal with the cost, deal with the geopolitical issues, and so on. So I just want to be clear here that I know this is a complex problem. But by saying that I think M6 is kind of at the heart of it all, I'm not trying to simplify it and say these are not issues, but you've got to have some foundation. And I believe we may have the tool that gives us the foundation to build from, to address some of these other issues. Next. Just want to again emphasize, it's not just, this is not a let's all go be missionaries meeting. I love what I've done, and I would encourage anyone who has an interest, I'd love to talk to you about things that may be happening in your life, that may be directing you, and I'm very happy to talk with you about that. But I don't want you to miss the point that we have opportunities right here. Next. Next, we have lots of things in Next. Lots of things that have been done here to try to address the problem, but there is unmet need right here. Next. So cost is a big issue. Next. The problem isn't just the number of surgeons. Let me come back to that. In some ways, it has to do with the quality of what's being delivered. Next. Here are the RAB studies that are these are all recent RAB studies, and if you're like me, they're heartbreaking. And I think you can see why. This is the report from well-accepted strategies for demographics in these countries developing countries where surgery is being done, cataract surgery is being done, about the incidence of permanent blindness as a result of cataract surgery. I mean, that's exactly the reaction. I see. That was my reaction. That was my reaction also. So I was in South Africa. I was sitting with the eye team. Woody, you were there. We were all sitting around this table, and they released that data at that meeting where I was there to train people to be eye surgeons. And they looked up and they said, well, according to this, it was studied. It was someone from India had come and done this study. I think that's right, Woody. Is that correct? They had come in and done the study, and they released this through the Fred Hollows Foundation. And they said, well, it's not too bad. Only 30% of the people who have cataract surgery are blind after cataract surgery. Obviously, we're doing great. That was appalling, shocking. I don't know the right words for that. But I tell you, there's nothing more motivating than seeing that was so clear that the perspective was completely off about the significance of this. This was, ta-da, aren't we doing great? And my point was, that's a disaster. It does not have to be that way. This is the shot across the bow as far as I'm concerned, that right there. We can't let that continue. Next. So that's a significant factor in terms of the patient satisfaction. Next. The negativity and what drives patient demand. I had cataract surgery. It was great. It didn't hurt. I see great. What drives patients away from surgery? Well, I was blind before I had cataract surgery, and now my eye hurts and I'm even worse off. Why don't you go have surgery too? It's really a great thing. Of course not. Next. Surgeon satisfaction. I sat in operating theaters with surgeons who were training to be, with residents who were training to be eye surgeons. And one of them came away from his first, so I walk up, he was just coming out of the room, and I think he was crying. I think Kim was there with me, and I said, "What's wrong?" He said, "I just wish someone would teach me how to do this." That's why we're here. Next. So their productivity is lower, their satisfaction is lower. So the faculty was sitting in their room. This guy, the resident, comes out and looks at me and says, "I just wish someone would teach me how to do this." The faculty was in the room on the other side doing their private cases. And they had said, "Well, just call me if you need me." That was their concept of training. I hope what we'll all come away with today is a much better understanding of training than that. That is not acceptable. Next. So I believe quality improvement really is foundational for all of this, and since M6 is at the heart of it, I think it's about training people in doing good quality manual small incision cataract surgery. Next. So how to get improved quality? Let's talk about that a minute, and I'll be finished. First of all, realize there's been a lot of attempts to do training. So I'm not saying this is unique, that training, the idea that better training is needed is not a new idea. Of course not. There's been a lot of work done with that. The Academy is very big about education and training, Academy of Ophthalmology. I realize that. But there's also some realities that perhaps have not been honestly addressed. For example, phacosurgery. Attempting to mainstream phacosurgery in these countries, there's some good studies now that is not a good way to start someone in their career path in a developing country. That was well documented in a study by David Chang. He said, if that's what you want to teach people to do as a start, you're going to immediately increase the risk to patients. That's not the way to go. Next. The cost of entry in the phaco market, of course, is also quite high too. So it's a double whammy. You're teaching them a procedure that is more risky to learn in the developing nation context for a variety of reasons. You can look at that study if you're interested. But then the double whammy is, now you've taught them to do a procedure that they're going to have to make a series of compromises to be able to even continue to do it. For example, well, I guess I'll have to reuse that tip 50 times because I can't buy another phaco tip, et cetera, et cetera, et cetera. You know what I'm saying? That it's the double whammy here is you've taught them a high-risk procedure and not really set them in a place where they're ideally equipped to deal with the problems of maintaining that. Next. And the problem, additional problem is that subsidies that have been provided to do that have tended to drive the market towards those who do have resources. In other words, the market where there is less of actually the need of what we're trying to address. So you can either decide, well, they'll all die eventually and the cataract problem will be solved, or you can say that's just not acceptable. Maybe there's another way to approach that. I'm sorry for being, maybe that's a little too harsh, but I've just lived that too long, maybe. So there you go. Next, the dangers of phaco. That's the article. So just it'll be in the slide set if you wanted to review that. It'll be there for you to look at if you'd like to. Thought it might be of interest to some of you. Next, so there's a convergence now of thought. Next, bringing together manual small incision as a new high quality, low cost alternative. Next. These studies are at a RAND study of M6 is at the core of the solution, concludes that M6 is currently the best alternative. I mean, maybe something else will come along. That'd be great. But at this point, manual small incision looks to be the best alternative. That article that I mentioned, the Chang article, actually concludes the same thing. Next. And there's many organizations. I'm part of Help Me See, so I think most of you know that. I just wanted to mention there's a lot of work being done on this. So I know this is a relatively small group, but I just want you to know that I think we all know we're not alone in the effort to address this. There's been a change. Some residency programs are actually starting to look at this quite seriously. I know, and thanks to Kyle and his team, and Scott and White, Nate Henson, and the work that he's done with them, and other programs. I think Dean McGee, is doing the same thing, I believe. And I'm sure other places also. But I know there's some movement in that direction to lay the groundwork, to lay the foundation for developing the tools that we all need to be successful with this. Next. Just very quickly, these are some of the landmark studies that were done. These were studies that were mentioned when David Chang did that Minkhorst lecture in 2008, or maybe it was 2009. I forget now. But he was the incoming president of the ASCRS, and he was wanting to say, my term is going to be marked by international success. That's what he was trying to say. I just have spent some time chatting with him about all that. Anyway, so he presented this data of how M6 was actually a truly up to the standards that we would all expect to use. That it wasn't a second best, that it wasn't, well, they're poor, I guess we'll just have to give them something, let's just use this. It's actually a very high quality tool to use. Next. This is just more of that. The endothelial cell loss, you can see, is quite low. In fact, it's a little better with M6 than it is with phaco, and these are in matched cases. So it's advanced cataracts, the ones that we say, yes, I can do it because I'm a great phacosurgeon, but it's a 4+ nuclear sclerotic cataract, and yes, you get it done, but yeah, there's a little corneal edema the next day, and this just says with M6 there isn't. So there you go. So next. So this all comes back then to the surgeon. In the end, it's a surgical problem, and that means surgeons are the solution to the problem. Surgeons, in the end, they're actually delivering the solution, is what I'm saying. There's a lot of parts to the problem, so of course I understand that, but in the end, it's you and the patient who's blind on that operating table that is providing the solution. Next. They have to deal with all the issues, the conditions. Next. And you can just kind of flip through these, establishing the parameters, controlling their costs, training their staff, mobilizing patients. I've worked with surgeons who have been going through that process. They need help. They need encouragement. They need people that are willing to stand alongside them and say, hey, we can do this. We can make this happen. Next. They have to work with the support networks, getting the supply chain to work and maintaining the equipment and establishing the social networks that bring the patients to them. Somebody has to do that. And typically it comes back to the surgeon. He's the one who's delivering the care in these places, in the low access places. So that's an enormous hill to climb, as you can imagine. And whether or not you are one of those people that's out there on the front line doing the surgery, or maybe, as we hope to challenge everyone today, maybe you're one of those surgeons that isn't actually out there doing the surgery. Maybe you're out there with one of those guys who's going to live with those issues every day to try to make this happen. Maybe you're one of those people that can help them do that. That's what we want to share with you, or things that you can do to be effective in supporting, encouraging, training these guys that are addressing all those things on a daily basis. Aren't you all grateful for your staff at this point when you think about that? I know I am. I haven't been in a practice for a good long while, but man, I had the luxury. I just could walk in there and I could see a patient, and then I could go to the operating room, and I never had to think about where all that stuff was coming from. I didn't have to think about, who was paying the staff and how I was going to make sure that all the credentials were met, and Jacopo was happy, and all the, et cetera, et cetera. You know the drill. I didn't have to worry about that directly. I had people doing that. These guys don't, and that means they need some help to do it. Next. Market forces alone have not been adequate to move the needle, I guess is another way to say all this. There's too many other factors. Next. So we need to be part of that solution. Next. I want to talk just for a minute. There's basically 4 parts to this very simple idea. We need to get the ball rolling, to increase that. Basically, there's 4 pieces to that, which is not rocket science. We need recruitment next, training next, deployment next, and support. Those 4 things. You get those 4 pieces kind of going, and maybe you can see yourself in one of those pieces. That's the reason I'm showing you this. We're not all designed for training. We're not all designed for being out there on the front line, but maybe there's something on that list that you're designed for, that you can see you're equipped for, that you feel a sense of drawing or calling towards. Maybe that's you. But I can assure you that we need help at every single level there. So be thinking and praying about that. Next. Next. So just to kind of wrap it up, I think M6 really does provide us a foundation because it provides a quality platform. Next. It is a low cost, so compared to FACO, the cost of delivering M6 is quite low. It's about 1/10 of the cost in most every study that's been done of cost analysis. It's about 1/10 of the cost of doing FACO, and that's even with subsidies, which of course FACO companies are of course need to do. They need to. There's high levels of subsidization for doing that. But it's even with that, it's not sufficient to say that the costs have balanced out. They really have not. And next, the medical conditions, including the surgical cataracts that we're talking about, of course, often, especially as we're talking about the backlog of blindness in these countries, the level of pathology is very high. And those of you who've done some of this work or have tried, as I did initially, way back when, of course I can do phaco surgery in a developing country. It's just they didn't know how to do it right. And of course I can, so no problem. I'll go and do that. And I was, of course, sadly mistaken. And fortunately, quickly, abandoned that and started working on better alternatives. So, the pathology just demands a better solution, I think, also. Next. And you are all the best resource for this. So I hope you'll be thinking next about how you can be part of this, because you've been given so much, and that to whom much has been given, much is required. It's just a spiritual principle. It's just that simple. Next. So this is intended to help you, help them. So when Stan said this is not about you, not about us, and it's really about us being servants. Us about learning to be serving those that really are in a place to address this problem at some level. Again, there's not one size fits all here. If I went around the room and talked to everyone here, there'd be all sorts of different interests. Everything from research and academics to Carlos, wanting to live dangerously, and everything in between. So, we all have a place in this, I think, if we just be thinking about that. Next. So I'm, again, very grateful for you all being here. I think, I forget who is next on the,